Hi, my name is Kelly Larson. This presentation will explore my completed doctoral project entitled A Cardiothoracic Pre-Operative Clinical Practice Guideline. I would first like to thank my committee members for the help with my project. This includes my chairperson, Dr. Aslin Moyer, my second reader, Dr. Stour, and the community member of my project, Rowena Chen. First, we will discuss the background and significance of my project. With a reported 17.5 million deaths per year, cardiovascular diseases remain as the leading cause of death worldwide. Surgical intervention for the cardiac population is furthermore utilized to provide patients with treatments to increase both quantity and quality of life. A common issue facing patients undergoing open heart surgery is the lack of education prior to operation, which causes both psychological and physiological consequences. Psychologically, patients undergoing surgery experience a heightened level of anxiety prior to operation. Preoperative anxiety is linked to postoperative mortality, increased risk of postoperative complications, and increased morbidity for patients undergoing heart surgery. Physical manifestations of anxiety can also occur, which includes tachycardia, hypertension, nausea, and elevated temperature, which can have detrimental consequences on recovery. Physiological complication can occur as a result and lack of knowledge prior to cardiac surgery. Associated adverse health outcomes include atelectasis, deep vein thrombosis, wound infections, sternal dehiscence, and pulmonary infection. For these reasons, education in the preoperative period is essential to improve the patient's recovery. Due to the significant psychological and potential physiological negative outcomes from lack of preoperative education, the purpose of the scholarly project was to create a clinical practice guideline recommending the standardization of cardiothoracic preoperative education. Recommendations included in the guideline were the creation of a clinical education brochure provided to patients preoperatively and the formulation of a clinical ethical binder for cardiothoracic nurses caring for patients in the postoperative setting. Secondary aims for this project focused on its future implementation. This included decreasing anxiety levels postoperatively for patients and families, increasing patient and family satisfaction levels, reducing postoperative length of stay in the intensive care unit, reducing sternal infections postoperatively, and reducing length of mechanical ventilator days. The significance of the project has numerous benefits. The nursing profession plays a key role in the integration of patient education for clinical practice. All state nurse practice acts include patient teaching as an essential core measure for nursing practice. Bastable found that effective teaching provided by a nurse can increase patient satisfaction, improve quality of life, provide patient compliance to his or her treatment regimen, reduce complications of illness, improve patient anxiety, and empower patients to become active members of their care. Due to the critical and beneficial nature of education for both patients and clinical practice, empowering patients in educational programs prior to surgery can provide both patient and nurse benefit. Through receiving detailed information prior to surgery, the patient will be an informed member in their care during the critical postoperative stage. This will allow the nurse to assist the patient on achieving essential milestones after surgery instead of focusing on education that could have been provided in the preoperative stage. In this way, both the patient and nurse can individualize the patient's care to optimize a successful postoperative clinical course. This project also has the potential to impact the healthcare setting for preoperative education systemically. Current research supports the administration of additional education in the preoperative period. The Enhanced Recovery After Surgery utilizes evidence-based practice and transdisciplinary care to promote patient outcomes through a patient's entire preoperative journey. In early studies, this program implementation in cardiac surgery has been shown to reduce complications and length of stay in up to 50% of patients in comparison to conventional methods. One important component of the ERA strategy is the utilization of patient education preoperatively. After asserting the background significance of the project, a literature review was conducted to determine if the evidence-based review supports the literature identified. For this project, a PICO question was formulated to further address the area in question. The clinical inquiry pertaining to the issue was, in the adult cardiothoracic patient population, how does education provided in the preoperative period, compared with the lack of preoperative education, influence a patient's psychological outcomes and physiological outcomes over their length of stay in the intensive care unit? A search assessing preoperative education was conducted to analyze the research pertaining to cardiac surgery education implementation. Upon review, 3 themes emerged: psychological outcomes after preoperative education, physiological outcomes after preoperative education, and educational sessions completed in the preoperative setting. Of the literature reviewed, an overwhelming number of articles discovered positive benefits in the implementation of preoperative education and a reduction of anxiety. The reduction of anxiety can have both psychological and physiological benefit. Ali et al. And Kiliani et al. Highlighted how psychological symptoms such as anxiety are associated with atrial fibrillation in the postoperative period. In addition, other physiological factors that are elevated with anxiety include sweating, hypertension, nausea, and elevated temperature. Through preoperative education implementation and a reduction in anxiety, these physiological outcome measures have the potential to be lowered in the clinical setting. Psychological symptoms associated with delirium were also found to be lowered with the introduction of preoperative education in the postoperative setting. Delirium is a frequent complication in the intensive care setting, affecting up to 57% of cardiac surgery patients. It is characterized by a dysregulation of both cognitive and daily fluctuation awareness. Sternal instability, respiratory failure, longer rates of intensive care stay, and an increase in mortality rate by 20 to 30% have all been reported. From this literature synthesis, preoperative education has a strong effect on the positive benefit of lowering a patient's anxiety level and risk of delirium in the postoperative setting. A multitude of studies also found that physiological outcomes for patients were improved through the implementation of preoperative education. Included in these physiological outcome measures was a reduction in sternal infections, reduced pain levels, lower rates of respiratory complication, an improvement in vital sign measures, and a reduction in length of stay. Negative physiological outcomes can result in an increased hospital stay, reduction in patient safety, and increase in treatment costs. Literature review synthesized, furthermore, found positive benefit in the implementation of preoperative education and an improvement in a patient's physiological outcome measures. The last theme that emerged to consider was the type of education the patient received. All studies synthesized in this review utilized preoperative education as their intervention for their cardiac surgery population. There is no noted standardization of the methods utilized for preoperative teaching. Technological aids, individualized education, and group education were all utilized in the implementation of preoperative education. Each study analyzed found positive results with perioperative education and clinical outcomes, despite the type of education the patient received. Therefore, different types of education can be utilized in the clinical setting during preoperative teachings for improvement in patient outcomes. The optimal theoretical framework for the STAMP project refers to Ottawa's model of research. Ottawa's model of research is a planned change theory that aims to change organization and systemic structures. The researchers of this model believe that research is a collaborative process, that patients are central to the translation of knowledge due to the patient's health outcomes being of utmost importance, and that knowledge translation processes are affected by the environment of healthcare. My project highlighted the importance of the patient being well-versed in their surgery to not only improve psychological outcomes, but physiological outcomes as well, indicating the patient's importance in their own health outcomes. In addition, with the more detailed implementation, an improvement in these measures showed the importance of the environment in improving the hospital setting for both patients and practitioners. To understand the implementation of Ottawa's model in this project, there are 3 facets to consider that are central in the research change process. This includes the research-informed innovation, the potential adopters, and the practice environment. The research-informed innovation is a change to be implemented in practice. The potential adopters refer to the current practice and knowledge skill level of the current setting, and the practice environment relates to the patients and structural facets of the hospital setting. In this process, the research-informed innovation is implementation of preoperative education in the cardiothoracic setting. The potential adopters of this project are the patients undergoing open heart surgery and the patient's limited knowledge regarding postoperative care. The practice environment for this project will be conducted at a 489-bed non-profit teaching hospital. The hospital undergoes, on average, 150 cardiothoracic cases per year. With this caseload, the importance of education prior to surgery is essential. Ottawa's model of research was applied utilizing 6 steps outlined in the model. This includes setting the stage for implementing the innovation, specifying the intervention, assessing the innovation, monitoring the knowledge translation strategies, monitoring the adoption of the innovation, and evaluating the researcher's performance. Each of these steps was accomplished in this project in creating a clinical practice guideline for cardiothoracic education. Next, we'll discuss methods and designs. The purpose of the study was to create a clinical practice guideline recommending the creation of clinical cardiothoracic preoperative brochure. The scholarly project itself was a non-intervention project in design. Therefore, an inquiry was not necessitated. Upon the literature review synthesized, a clinical practice guideline was rather created. Recommendations were formulated through evidence-based recommendations asserted in the review. This includes the creation of standardized pre-operative clinical brochure and the creation of clinical educational binder for cardiothoracic staff nurses. I then presented the final clinical practice guideline to 3 appraisers. Using the appraisal of guidelines for research and evaluation tool, or the Agree-To instrument, the stakeholders evaluate the guideline. The Agree-To tool utilizes both qualitative and quantitative data. Each domain scores involves quantitative data, ordinal in nature, to appraise 23 subsets of the guideline in a 7-point scale. Nominal quantitative data was also collected in the final 2 questions of the instrument. The appraiser was asked to answer yes or no on whether the guideline should be implemented into practice. Qualitative data of the instrument consisted of the ability of each appraiser to leave comments to provide further feedback for the review of the guideline. After the appraisers evaluated the guideline, the author collected the data and analyzed the appraiser's scores to evaluate guideline quality. This analysis determined the guideline's clinical strengths, clinical weaknesses, and any guideline enhancements deemed necessary prior to implementation. The Agree-To tool was selected due to its strong design. It has both reliability and validity testing. It is one of the most frequently used instruments for clinical guideline development and ensured I was creating a quality guideline through its utilization. Next, we will discuss sample. As highlighted, the scholarly project did not include human participants. Rather, a clinical practice guideline was developed and evaluated by 3 appraisers. The appraisers were identified based on the following inclusion and exclusion criteria. To be in consideration as an appraiser, the stakeholder involved had to be currently working in a healthcare setting, be over the age of 18, have expertise in cardiothoracic management, and have direct interest in post-operative cardiothoracic management. Exclusion to be an appraiser in this project include working in a setting outside of healthcare, being under the age of 18, having a role outside of cardiothoracic management, and not having an influence on post-operative cardiothoracic management. After 3 appraisers were identified, each participant was asked for voluntary participation in the study. Voluntary consent was given by each appraiser for providing their feedback for the clinical practice guideline using the Agree-To instrument. An open line of communication was continued throughout each individual evaluation of the clinical practice guideline, as recommended by the Agree-To instrument. Next, we will discuss data analysis for the project. The Agree-To tool was utilized for method evaluation. The instrument has been rigorously evaluated and meets criteria for reliability, construct validity, and criteria validity, which made it an easy choice for instrument selection. The Agree-To scale is ordinal qualitative data and focuses on ensuring 6 domains of the guideline are met. These 6 domains include scope and purpose, stakeholder involvement, clarity of presentation, applicability, editorial independence, and rigor of development. These 6 domains highlighted are divided into 23 subsets and are evaluated on a 7-point scale. An additional 2 questions were also evaluated by the appraiser for overall guideline quality. After data was collected by each appraiser, the following equation was utilized to compute the information. This includes obtained score minus minimum possible score divided by maximum possible score minus minimum possible score times 100 for percentage. Using this equation, the results were computed and evaluated for clinical guideline quality. The final 2 questions computed evaluated whether the appraiser recommended the guideline into practice. 3 possible nominal data answers were ascertained. This includes no, yes, or yes with modifications. The final quantitative component of the guideline asked the reviewers to rank the guideline on a 7-point scale for overall quality. Comments were also optional for the stakeholder to leave for evaluation. Using this equation, results were as followed. Both nominal and ordinal data was collected by a Agree-To instrument for analysis of the quality and strength of the guideline. This data was inputted to produce scale domain scores for each of the 6 domains examined. A threshold set by the author of greater than 90% was computed to ensure the guideline met excellent quality for each of the domains measured. The highest score was calculated at 100%, while the low score was computed at 90.4% for domain 5. In addition to the domain quality scores computed through 23 items, the Agree-To instrument also factored in a 2-item questionnaire at the end of the instrument for the appraisers to assess the overall quality of the guideline. This was reported in both numerical and survey form. All appraisers rated the guideline as a 7, indicating the highest quality guideline. Each appraiser also stated yes for implementation of the clinical guideline into practice. One appraiser stated in the comment section of the instrument that the guideline was excellent in design, ensuring evidence-based collaboration for the implementation phase into practice. Based on the results, it was determined by the author that the clinical guideline met high-quality standard as outlined by the methodological framework of the agreed-to tool. Revisions were not indicated, and the guideline was ready for practice implementation. Despite favorable results, limitation for the project did exist. While the benefit of a policy revision project includes eliminating time constraints, selection bias, issues with patient confidentiality, and confounding variables noted in intervention studies, this also serves as a noted weakness. A study design for the project would have had the potential to provide valuable insight into measurable outcomes of implementing the guideline into practice. However, due to time constraints, the guideline is now in the preliminary phase of the implementation, and its effects were not able to be measured for this doctoral project. Its potential benefits for the cardiothoracic population are therefore idealized until implementation can occur. Since the clinical guideline is currently being implemented into practice, this limitation can be adjusted once clinical outcomes can be measured. A major limitation of using the agreed-to instrument is the subjective nature of the appraisers reviewing the instrument. Since each appraiser had a strong interest in updating current pre-operative education for cardiothoracic patients, this may have served as a bias to the results each appraiser concluded. For this consideration, each appraiser selected verbally stated their willingness to appraise the guideline in its entirety without coercion or influence from the author. The goal of the project was to create a clinical practice guideline that recommended the standardization of pre-operative education for the cardiothoracic patient population. To achieve this, recommendations include creating a clinical education binder for cardiothoracic nurses and providing a brochure on post-operative education for patients during their pre-operative period. The summation of these results computed indicated that through a methodological framework, a high-quality clinical practice guideline was created. Clinical practice guidelines are cornerstones of healthcare to assist in changing practices based on evidence-based research. Benefits of guidelines include addressing gaps in research, providing explicit recommendations for healthcare professionals on how to proceed, and improving efficiency of healthcare systems. Once a clinical guideline is developed and meets high-quality expectations, implementation strategies should be considered. Thusen et al. Evaluated 62 clinical practice guidelines with implementation strategies. The authors found that 85% of guidelines found positive patient outcomes with initiation. Each guideline analyzed also met methodological strength, further supporting its design for implementation in the clinical setting. With a high statistical success rate founded when implementing high-quality clinical practice guidelines, as demonstrated in the above study, the final goal of the author's clinical practice guideline is to implement the guideline recommendations into practice. Based on the literature review synthesized in this project, studies have shown positive benefits in implementing pre-operative cardiothoracic education into clinical practice. By following the recommendations outlined in the clinical practice guideline created, the hope is that a similar improvement in the patient's psychological and physiological outcomes will be seen at the author's clinical setting where the guideline will be implemented at. Implications through its implementation can improve future research, future practice, and health policy. The formation of the clinical practice guideline is already in the process of enhancing future research and practice. The cardiothoracic manager of the unit was enthusiastic in implementing the recommendations of the clinical practice guideline. A throughput committee was already in the preliminary stages of being formulated at the beginning of the author's doctoral project. After the conclusion of the clinical practice guideline, a pre-operative throughput group was created, and the recommendations outlined by the guideline were followed. This includes the creation of a clinical practice brochure for pre-operative patients and a clinical binder for cardiothoracic nurses regarding essential patient education measures. The next step of advancing the clinical guideline recommendations is to give each pre-operative patient the clinical brochure created. After implementation of the guideline is successful, then outcomes pertaining to the guideline recommendations can be measured. This is anticipated to be a 2-year process per the cardiothoracic manager's conclusion. Healthcare policy, according to the World Health Organization, relates to the accumulation of choices and executions carried out to achieve the goals of healthcare and society. This is accomplished by undertaking quality improvement projects that both improve patient outcomes and cost burden to the organization. The implications of this doctoral project, when considering the implementation phase, can have the potential to both improve patient outcomes and lead to a cost reduction for the hospital. As the literature review explored, the relationship between preoperative education for the cardiothoracic patient has supporting literature demonstrating an improvement in outcomes. This is essential in considering the financial impact it can have for hospitals. The Centers for Disease and Medicaid Services focuses on 5 quality metrics in hospital reimbursement. This includes readmission rates, patient experience, patient mortality rates, safety, and timeliness of care. As evidenced by literature, increasing preoperative education has shown statistical improvement with increased patient satisfaction rates and lower hospital mortality rates. In addition, in one study conducted, the implementation of preoperative education led to a reduction of 1,492, or an 18.9% decrease for each hospital stay. It can therefore be induced that standardizing education in the preoperative state has the capacity to provide a substantial and cost-effective policy reform through its implementation for both patients and hospitals. To conclude, the focus of this project was to form a clinical practice guideline recommending the implementation of a standardized approach to cardiothoracic education. The guideline is currently being implemented into practice at the hospital setting it was conducted at, and its impact will be evaluated after completion. In the future, I plan to evaluate the data guided by the implementation phase of the guideline to evaluate if standardizing preoperative education for patients was successful at improving patient outcome measures. If I could redo part of this project, it would be to reach out to the manager earlier to implement this project sooner in the clinical setting. This program has advanced me both personally and professionally. I now have a greater understanding of research and the methods it takes to accomplish change in a clinical setting. It has also taught me personally that through resilience and dedication, we can continue to improve ourselves and achieve higher levels of education. Thank you, and I hope you all have a good day. And here are my references.